But to start off, we're going to go to the basic embolization techniques to make sure we're all on the same page. And I'm going to ask Dr. Tim MacFall, one of our interventional radiology fellows at the Medical University of South Carolina, to come up and get us started. Tim?
First off, I'd just like to thank John for putting this meeting together and all the coordinators. Thank Dr. Selby for inviting me to come and talk. What I'm going to talk about this morning is endovascular techniques to control bleeding, kind of an overview of the armament that we have for embolization. I don't have any disclosures at this time. As most people know, Charles Dotter, as a history of embolization, treated a first SFA occlusion back in 1964 in an 82-year-old female who had gangrenous toe, was not considered an operable candidate. He published it in Circulation Journal in November of 1964, went on to have a pretty extensive article in Life magazine. This was one of the pictures of him in the original article. This went on to further be used with Dr. Roche, who was working with him, and they were using catheter-directed low-dose vasopressin for control of GI bleeding. During this time, he thought up a new technique, selective arterial embolization, in November of 1970 using autologous blood clot. Now what they did was they preceded and followed this injection of blood clot with epinephrine. And what that did basically was kind of hold that blood clot there so that they could get embolization. This further went on, progressed to Dr. Lunderquist, who at the time in the early 70s, kind of late 70s, was doing transhepatic variceal embolization using a sclerosing agent, either alone or with gel foam. And then this has kind of progressed into what we do today. Now, in my training, as well as most of you, I'm taught that before we even start a procedure, the main thing to know is to have a plan. We start off with the goal of the procedure. What is it that we are trying to do? Are we trying to just decrease the blood flow? Are we trying to have complete occlusion of the vessel if we're trying to embolize something, or are we going after some type of tumor that we want to make sure stops blood flow, or to stop blood flow to the tumor? The next thing is level of occlusion. Are we looking at proximal, distal? Are we going for capillary embolization? And then the delivery system, how are we going to get there? Do you think we can get there through a diagnostic catheter? Do we have to get a microcatheter out before we start embolizing with what we're going to use? It's not moving forward. The next thing we want to look at is in our planning procedure is what is our approach? What's the major blood supply to what we're going to do? The accessory vessels, the collateral vessels. We want to make sure that we have all of this before we even get in there. If we're using a CTA as our guidance, how we're going to get there. Lastly, or second to last, is adjacent structures. If we're using some type of embolization agent, we want to make sure that we're far enough along that we're not obstructing or having any type of non-target embolization. And lastly, we're always taught to think of complications even after the procedure, whether it be a hematoma from a dislodged closure device or some type of complication afterwards. We want to make sure that we're aware of those and plan for those before we even start the procedure. A lot of times you'll hear embolization categorized as temporary versus permanent. For my talk today, I'm going to classify embolic agents in these 4 categories, and I'm briefly going to talk about covered stents at the end. For particulate agents, autologous blood clot, gel foam, PVA, these are the main things that we use for particulate agent embolization. Autologous blood clot, although not used significantly today, but can be gained either from the vascular access where we pad our sheath or from a peripheral IV. Usually let it sit around on the table for a few minutes. 5 minutes is usually long enough. And then we usually aspirate it into a syringe. You want to make sure that it has some type of contrast mixture in it, some type of 50-50 mixture, 70-30, so that you can actually see it when you inject it. And because of the viscosity of a blood clot, it can be injected through the microcatheter. You don't need a diagnostic catheter to inject it. Gel foam, second agent, as a particulate agent used or originated from subcutaneous porcine adipose tissue. It's available as a powder, although we don't use it much as a powder. Most commonly is used as the sponge or the block that we get. It is a temporary occlusive agent. It's not for permanent occlusion. It's notoriously known to recanalize usually in a couple of weeks to a couple of months. And because of its small size, it can go on and have more distal occlusion, which increases the risk of having tissue ischemia. A couple of ways you can use gel foam. One is a mixture with through a three-way stopcock and make a slurry. This is a patient that came in through a trauma. You can see here, you can see that there's a little bit right there of extravasation seen on the CT. When the patients come in, they get their trauma scan. The patient was brought to the angiography suite. We did this initial run. You can see active extravasation there in the inferior aspect of the spleen. Just another close-up view of it. This was actually treated with a gel foam slurry, and you can see in the final image that there's no further extravasation of contrast from the traumatic laceration there. Next thing you can use gel foam with is a pledget or a torpedo. Cut a small little piece of it, roll it up on the back table, and inject it either through a large diagnostic catheter, or sometimes we use these for biopsy tract embolization. It can be used in combination therapy. If you have coils as your scaffolding, then you can inject gel foam on top of that just to kind of increase the stagnant flow, to increase the occlusion of a vessel. Particulate agent, the last one is polyvinyl alcohol. It's an inert, permanent embolic agent. This is not temporary, it is permanent. It's not radiopaque, so you have to mix it with contrast so that you can see what you're embolizing, or see it as it comes out of the end. It's usually carried to the site of embolization via the blood flow. It follows the flow. And then it manufactured comes in multiple sizes, either ranging from 100 to 2,000 microns. Usually the most, what you're looking for when you do PVA is stasis of flow. That's their endpoint. We always want to make sure that once we have stasis of flow, we know that we've embolized enough. And not only are we using things for acute trauma or acute bleeding. This is a patient who came in with a left renal cell carcinoma that was sent to us by surgery preoperatively to embolize the tumor. On these angiographic images, you can see the big tumor blush. This was embolized basically to control bleeding when they went in and took this tumor out. This was embolized successfully with 2 vials of 500 micron PVA, and you can see the stasis of flow at the endpoint. It is important to note that even once you get stasis of flow, you should not forcefully inject, trying to force it forward. You want to make sure that you're not refluxing any of that. Forceful injection can actually reflux that PVA, in this case back into the aorta, and have some type of non-target embolization. Next, we're going to move on to mechanical occlusion coils. There's a couple of different kinds right now. We have pushable and detachable coils. They come in variable sizes, variable lengths now. Configurations, they have straight ones like this, the halal coil, the helical, they have spiral. And now today we have multiple different ways that they kind of create or increase the thrombogenic response. The fibers that have been around for a long time, but this new hydrocoating or hydrogel coating, once the coil is packed in, it kind of expands to further occlude the vessel, kind of pack it in, make it tighter to increase the stasis of flow. The other one is the PGA polymer that's actually within the coil that kind of expands and helps for tighter packing and stasis of flow. Deployment, stifle coils should also always be deployed first. You want to make sure that you have a good scaffolding to pack other coils on top of it. Whenever you use pushable coils, a lot of times we'll use a saline bolus with a 1 cc syringe through a microcatheter. You want to make sure that if you're going to use a wire to push it, you want to make sure that the wire is appropriate size. You don't want them to overlap when they're in the microcatheter or in the diagnostic catheter. Detachable coils are more for precision deployment. We can pack multiple coils on top of each other, and if they're not looking the way we want to, or they're not seating right, we can pull them back into the microcatheter. And we can wait and detach it when we feel like we've got a good position. Sizing of coil embolization, sizing is very important. You want to make sure that you have the right size. If you do choose a too small of a size, you can actually get a distal embolization. This is a case that I did early in fellowship that we had. Patient was sent to us. You can see the clips there. He'd already been to endoscopy. We got our diagnostic catheter in, microcatheter passed. They were unable to control the bleeding, so they called the patient or called us and sent the patient to us. Unfortunately, the first coil that we attempted to put in was undersized. And you can see we did get a good response with the embolization here, but right up there, you can see the first coil that we put in that actually went a little bit farther than we had hoped. On our final run, you can see, though, that we did get good embolization and control of the bleeding. Oversizing is also important. You want to make sure that you don't oversize the coil. You won't be able to deploy it into the vessel if it's not sized appropriately. The second to last thing we're going to talk about is embolization liquid agents. And in this category, we have 2 things, glue and onyx. Glue is a rapidly acting liquid. It polymerizes as soon as it comes into contact with the blood, the ions within the blood. There's a small exothermic or heat-related reaction once it polymerizes, which can also affect the embolization and occlude the vessel. This is a patient that came to us from a trauma, again, another splenic injury, where we see a little bit of extravasation. This middle portion where looks like there's a wedge segment that's not perfused, it's actually perfused. I'll show you in a minute from an earlier artery, but you can see the extravasation there. We had our microcatheter out. We embolized with liquid, with glue. You can see the glue cast there, and there's no evidence of extravasation. And you can see that wedge-shaped area was perfused by an early branching vessel, so we were able to preserve, looks like about 80% of the spleen. Remember that whenever we use glue, you have to flush the catheter with dextrose. What that does is once it's inside once the glue is inside the catheter, it prevents, once you put the dextrose in the catheter, it prevents the glue from polymerizing in the catheter itself. It's usually mixed with iodized oil. It increases the polymerization time, means that it takes longer for it to solidify once it gets into the bloodstream. The iodized oil also gives it its radio-opaque properties. Onyx is a non-adhesive, non-absorbable, permanent liquid embolic agent. It's comprised of ethylene vinyl alcohol mixed with DMSO. The micronized tantalum powder that is what gives it its radio-opaque ability to see it under fluoroscopy, usually delivered by controlled injection through a microcatheter. There are certain microcatheters that it is designated to be used with. And again, we pre-fill the dead space with DMSO right before we inject it. Comes in 3 formulations. The lower the number, the lower the viscosity. The higher the number, the higher the viscosity. And the higher the viscosity theoretically gives you better control of the embolization. It's slow to solidify. It's an outside-in process, kind of if you think about it like lava. When lava gets cooled, it solidifies from outside in. If you pull the outer crust away, it's still somewhat liquid on the inside. This is a patient who had a previous aortic bypass for aortic aneurysm. You can see the medial aspect of the aorta there. There's a type 1 endoleak. We were able to get a microcatheter up just into it. You can see contrast extravasating out. We're right there by it. And this image is another digital subtraction image. This is where we're just injecting contrast, and you can see once we get a microcatheter in there, through the microcatheter, we end up injecting onyx. This is actually our onyx cast in the endoleak, and I think you can pretty much see that the onyx just pretty much formed into that cavity that was created by the endoleak, as the two look very similar. At the end of the procedure, the follow-up image, there was no evidence of a persistent endoleak. This is a little bit of a chart that I found that kind of compares onyx and glue. And the biggest one is the preparation time. Glue, whenever you use glue, it's immediately available for injection. The onyx obviously takes 20 minutes. You put it on the shaker and shake it up for about 20 minutes before it's ready to be used. Last thing I'm going to talk about just briefly is covered stents. It's a way that we can control bleeding. There are 2 different types, basically: a self-expandable, balloon expandable, multiple different size ranges. This is a patient that came to us. There was an overzealous resident who was on the floor putting in a temporary dialysis catheter. As you can see, it actually is on the left side coming down. What we found out when the patient had a CTA was that this was in the subclavian artery and going down into the aorta. We were asked to take a look at this under angio and see if we could embolize this. There was a CTA. This is our first subtraction, or a couple during the procedure. We have an ICAST or atrium stent that's up there. You can see you can see right here, this is the vertebral artery coming up. This is where the stent is actually, or the temporary catheter is actually coming in and coursing down. We were going to try and preserve this. Unfortunately, we put in 1 stent. It jumped a little bit forward, put in another ICAST stent, and eventually, this was the first deployment. It moved a little bit farther than we wanted it to. But eventually, we, after 2 ICAST stents and a Vibond stent, we were able to completely cover this once the temporary catheter was pulled out or explanted. So in conclusion, always have a plan even prior to the procedure. The reason that when they pulled the temporary catheter out, the reason the procedure went well is because we had really planned on what we were going to do for that. In our armamentarium, there's multiple agents that we have now for embolization or endovascular control for bleeding. And there's different reasons that we do endovascular control for bleeding, not only for trauma, but pre-surgery to control blood loss.
I'm going to get this one up. Stay for a second.